Good afternoon, everybody. Welcome to today's webinar, Service Redesign, a Wicked Problem? Welcome. We're just waiting for everyone to join and we'll be with you very, very soon. Just to remind you that you're being placed on mute as you join, and we encourage you all to use the Q&A function for questions. The webinar is being recorded and will be made available to everyone that's signed up and on our web page. Please do introduce yourself on the Q&A so we know who's joined us. And we'll have lots of time for questions at the end. So without further ado, I'm going to ask Larry, our chair for the day, to start today's event. Thank you.
Good afternoon. My name is Larry Koyama. I'm a physiotherapist by background. Currently, though, I'm working as a senior consultant for PPL, a social enterprise that provides consultant services to NHS and care services as well. I am also a DARSI alumni and a current versus arthritis MSK champion, and will be your chair for today. So very welcome indeed. This is the 10th in the series of Connect Health Change webinars, which has been running since July last year, covering a range of topics from first contact practitioners, education, quality improvement, code, rehab, pain, and psychology. Today's topic, as Ali has mentioned at the beginning, is service redesign, a wicked problem, learning from mistakes and activating evidence for the right way to redesign services. As we go through, each presenter will speak for around 9 minutes, followed by an immediate set of questions. But we'll make sure the majority of the questions come at the end. So I do encourage you to post your questions as the webinar goes on, because we will then select the questions at the end from what has been posted. We have an absolutely brilliant lineup of speakers for you today. Their full biographies are available on the Connect Health Change webpage. So I want to thank you very much for joining us today. If you're watching this back, welcome. It's also an opportunity for you to revisit some of the previous webinars that have been done. The makeup of the people who have registered today is also really interesting. We have a really diverse range of people who've registered and who are attending, from managers in the NHS to people working as clinicians. We've also got people from all over the country at the moment. So I think this topic is very topical and will be relevant, particularly in the kind of context that we're in at the moment, both in terms of COVID and some of the changes that have gone on there, but also in terms of some of the proposed changes in the NHS white paper. The webinar will aim to cover a range of topics, as you can see from the agenda. Some of those would be the importance of asking the right questions, considering what you need to do to make it work and the context in which we're doing that, taking real life examples of redesign transformation programs, but also applying some of the theory into practice and starting to understand complexity and the ability to make meaningful change. So without further ado, I'm going to introduce our first speaker, Rob Webster. So Rob's the Chief Executive of South West Yorkshire Partnership NHS Foundations Trust and West Yorkshire and Harrogate Integrated Care Systems, who will hopefully begin by setting the scene. Welcome, Rob.
Thanks, Larry. Hello, everybody. My name's Rob. As Larry says, I'm the Chief Exec of a trust and the Chief Exec lead for an integrated care system, which we call a partnership, because that's what it is. And I'm going to talk a bit about the context, a bit about transformation, a bit about change, and hopefully really set the foundations for Becky and the others to follow on. I'll start by saying really that the trust that I work in operates in a number of different settings. It delivers community services, mental health, learning disability and wellbeing services, as well as some specialised services which are commissioned regionally. And the partnership that I lead is big, 2.7 million people, and complicated, with lots of organisations in it. And I mention that because it's really germane to some of the issues around service redesign and change. And I just wanted to make some remarks really about some of the features of service redesign and change that have been important in the current context within which we find ourselves. Now, the first thing I'd say is that in any complex system, we have to start from the right point. And the right point, I think, is purpose. And, you know, in my trust, that our purpose is really clear, where we exist to help people fulfil their potential and live well in their community. You'll notice that we don't talk about the NHS, we don't talk about health, we talk about people, we talk about potential, we talk about community. And already you can see that we're thinking about the fact that we're a guest in people's lives, and there are other actors who are also guests that we have to work with if we're going to help fulfill their potential and within their communities. And in our integrated care system, you know, we exist to improve outcomes for local people who face some of the most devastating health inequalities in the country, to manage unwarranted variations in care in that complicated system, and to make sure that we use our resources wisely together. And in doing so, we can advocate for and improve the wider determinants of health. So if we start from there, we've always got somewhere to go back to if the change conversation gets sticky. So I think that's the first point I would raise. And in any change, in any transformation, I think there are two lenses which I always look through. The first is one of culture, and the second is one of infrastructure. And I'll illustrate what I mean with a real example. So you need to have the right culture, and you need to have the right infrastructure for redesign and change to happen. So what do we mean by culturally? What sort of culture do we need? Well, let's take the not invented here syndrome, which we've had within the health and care system for many years. And in West Yorkshire and Harrogate, that was no different. So something that was invented in one place wouldn't be adopted by somewhere else. What we've tried to do in West Yorkshire and Harrogate is replace that with a pinch with pride approach. So if somebody's doing something well, let's nick it and let's do it better. So the example I would give you is around cardiovascular disease. And I'll come back to that in a moment, but you've got to have the infrastructure as well. So there's no point in having a good idea or a change if you can't implement it, if you can't make choices and decisions, if you can't allocate resources to it. So the infrastructure is important. So prior to the integrated care system existing, we had a culture which I think was not invented here, and we had no infrastructure for making decisions that were meaningful and that would stick. Once we created the integrated care system, we had several things which helped. So the first was to say, look, you know, if we're going to work at West Yorkshire level, we're either going to tackle wicked issues, sharing a good practice, or things that have to happen at scale. So already we're saying this is a culture where we share good practice and we adopt it. In terms of the infrastructure, we created a joint committee of CCGs that met in public, could make decisions which didn't require a consensus, supported by a clinical forum made up of people from right across the system that could make recommendations, tapping into evidence from the Academic Health Science Network. So Bradford Healthy Hearts was a fantastic project which was born out of general practice, which looked at how do you get in touch with, case find and support people who have blood pressure issues, heart failure, who you would normally find when they've had some kind of event and they're in A&E or they're dead. And if you look at your local public health report from your Director of Public Health, you'll find that the inverse care law persists and cardiovascular disease in poorer communities is too often diagnosed in the emergency room. Now, the integrated care system had just decided through the Joint Committee of CCGs on the evidence of the HSN through the clinical forum that you need to tackle atrial fibrillation. and we implemented a program of implementing changes which would manage atrial fibrillation and prevent strokes. And because we had a joint committee in a clinical forum, the infrastructure, and because we had a culture that said, let's share good practice and pinch with pride, the clinician said, well, what else have we got as well as evidence on atrial fibrillation? Somebody, what about this Bradford Healthy Heart stuff? Now, 2 years before, the Bradford Healthy Hearts work had tried to be rolled out by the CCG, saying, do you want to have a go at this? And I'll give you a direct quote from one of the places, which wasn't Bradford, which refused to do it. We're not doing this because not only was it not invented by a cardiologist, it was invented by a GP, but it also comes from Bradford. Now, we changed the culture, changed the infrastructure, and on the back of that, what we've done is roll out Bradford Healthy Hearts. So it's now West Yorkshire Healthy Hearts. It's clinical led, it's delivered in all the communities. We've identified and managed the blood pressure of thousands of more people who would have not been case found, and we're preventing strokes and heart failure every day. So culture and infrastructure are important in the ICS and in your organisation. And you've got to ask yourself, do we have the culture? Do we have the infrastructure? In my trust, we recruit for values, and one of the values we have is that we aim to be outstanding and we improve. So it's hardwired into the culture of the organisation. I've only got a few minutes. I'm going to make 3 or 4 other quick points before my 9 minutes is up. None of that works unless you have a model of change. So it doesn't really matter. If you look at the evidence, it actually doesn't matter which one you choose. It could be Virginia Mason, it could be Lean, it could be something else, but you should have one. None of that will work unless you have data about the impact that you're having, that you can get quickly and in real time, which will drive decision making. None of that will matter if you keep flogging a dead horse on something that's never going to work. Stop doing it and start doing something else. And none of that will matter unless you've got the right diversity of thought and leadership within your organisation and your system. That can come from citizens, that can come from people from different backgrounds and organisations, but you must have that diverse thinking. Richard Stubbs' work on this shows, for example, that if you have ethnically diverse leadership, you can drive better improvements in services. This is a leadership issue, and leadership happens at all levels. It happens in systems, it happens at all levels in your organisation, and it's values based. And if one of your values is that we improve, you've got a better chance. 2 final things I'll say, because I can see Larry's getting a bit edgy about the time there. The first is that if we look at change and improvement and the COVID experience, there's a lot of conversations that say, well, look how far we've come in COVID. We've introduced A, B and C. We've done a piece of work in West Yorkshire and Harrogate that says, why was that? Because there's 2 ways you can approach this. We can say everybody should do A, B and C, or you could say what were the conditions that allowed A, B and C to happen, and how do we keep those conditions so that we can always improve? And we found from a bit of research that there were 8 different dimensions that we had to work on to keep this in, this improvement focus within our system, rather than just focusing on A, B and C. And the last thing I'll say is that we're a big fan of Myron Rogers' maxims in our system. And Myron was based, Myron, you might be on the call, I don't know. Myron's done a lot of work in post-conflict areas. And his approach is people own what they create. The way you approach the development of something will define the thing itself, and you connect more of the system itself. So these things have put us in really good stead for our change journey in my trust and in the system, and has led to genuine improvements which are sustained. So I think that's 9 minutes. There's so much more I could tell you, but I will stop there.
Thanks, Rob. That was excellent timing. Rob, can I just put a question to you, if you don't mind? So I think you shared some really valuable insights there. In terms of the vast experience that you've had in redesigning services and particularly in bringing the community with you, what has frustrated you most and how did you go about resolving some of those challenges?
Well, I think frustrations is a function of expectation. And I think what I've learned over time is if you want change that's embedded, it's worth taking a bit more time to get it right. And I think that the thing I've come to realise is I don't have all the answers. In fact, I might not even understand the issues. And I know Becky, who's on next, taught me a while ago that you should co-produce the issues, not just what the answer is, because you might actually be focusing on the wrong thing. So the thing that frustrates me sometimes is that people start down the change journey saying we want to do this, how are we going to do it? Instead, they should be starting with what is it that we need to fix from a service user perspective, from a staff perspective, from a citizen perspective. And I think you can overcome that by getting the right people in the room from the beginning and really listening, and then working together on a solution. And the assets that people bring with them to that conversation are the thing that will get to the solution. So I think I always approach it in that way. And the other thing that really frustrates me is when people's assets are wasted. So we call someone a patient and then waste all their assets because we've labelled them, put in a box, said we're here to treat them. What we should be doing is recognising you've got somebody who lives with an issue, is probably pretty well informed, has a view, has lots of experience, and can then move on with you. So I have some frustrations, but I think there's always solutions.
Brilliant, Rob. Thank you very much. Like you said, we can probably spend a bit longer talking about that, but hopefully we'll get some questions towards the end. But I'll just move on to Becky's talk. So it's a real pleasure for me to welcome Professor Becky Mulby. So Becky is a professor in health systems innovation at London South Bank University, and Becky's work is inspirational to lots of people, particularly some of us who are DASI alumni. And it spans from co-production to primary care to innovating in new models of care and really working towards high-performing health systems. So with no further ado, Becky, please take us through top tips from theory to practice. Becky, I think you might be on mute. You might just start again, sorry.
Thank you. So just lovely to follow on from Rob. I hope it will just be seamless because much of what I talk about will be really following on the same principles. So first slide, please. So we did, as I guess Rob did, we did a survey right at the beginning of the pandemic about what was it that was working. There was plenty that wasn't working, PPE, the level of distress, the terrible numbers of deaths. But within all of that, some of the NHS England's talking about it being a learning system. Let's get underneath it. What we saw was some of the things that you see in lots of high-performing health systems around the world, actually. We saw people being properly valued. We were using 21st century tools. Leaders were absolutely walking the floor, well connected, much as Rob does himself on a day-to-day basis. But for some organisations, that was more unusual. The basics were fixed. We had joined up health systems. I don't know if you remember discharge to assess, Larry will remember this, where it was absolutely impossible to get anybody through that. It would take years to work out whether a social worker and a therapist could jointly assess somebody. Suddenly all that was taken away and it was possible to do things together. People were working really well as teams. They were checking in, checking out. Particularly, I think, because of the emotional labour of the pandemic. That we were honouring that it was an uncomfortable time. So you'd see primary care teams, GPs, receptionists, you'd see ward teams, you'd see hospital teams and community teams just checking, how are you? How are things today? And doing that during the day and checking out. Very simple, very important team processes that enable teams to be really fantastic together suddenly became the way we do things around here, whereas they just hadn't been before. We were like an automated machine just getting on with the stuff. Staff were stepping up and acting professionally. People were learning internationally via WhatsApp groups on, how to prone people, how often to prone people. We were making decisions based on needs, thinking more proactively about that, make mutual decisions with patients as partners. Communities were stepping up, as Rob said. The NHS asked for help and people stepped into it, whether it was in my community, we were making scrubs, we're volunteering to support the vaccine hubs. A massive amount of volunteering generated during the next one. Next slide, please. So what we saw. Okay, so what I want to share with you is some of the top tips for. So what is it? What happened? What is it? What is it about change that for a period of time in a crisis we seem to be able to do, but we just don't seem to be able to do on a day-to-day basis? And what we always suggest with is that you always have to start when you're approaching any change with what's really going on around here. Now, what we see in the NHS is often a set of fantasies. People sit around a table and say, I think it's this. I think it's that, and it's mostly based on experience and hearsay, and the last time I did this, or it might be based on power, or it might be based on authority. But actually we teach our DARSs, Rob does the same. We say, well, what is really going on around here and how do we know? So we say you can't get there from not here. So if you work at a fantasy level about what's happening, then all you do is keep sticking plaster the fantasy. So let's say health inequalities, Rob's doing some amazing work on that. What we said was we were offering universal healthcare and that everybody had equal access to the NHS. No, it doesn't. We know it doesn't. We've seen it doesn't, but we were pretending that it did. So when I look at GP practices, what I find is that young people aged between 7 and 24 are very rarely accessing primary care at all, but some people are accessing it all the time. Now, every GP is being paid its £94 a head. But actually what they're doing is taking that money from some people and giving it to somebody else. Now, you could say that's based on need, or you could say that's based on appointment systems and who has the loudest voice. Until we understand that, we can't change it. And that's the same for how we do all our health service provision. We've got to just drill down and understand what's really going on around here. And then we've got to say, actually, there's so many things we could change. What have we got passion and energy for? What are we enthusiastic for? What do we as a team think we can put some effort into? And what we learned in the pandemic was we had access to some real-time data. We tried to find out what's happening because we hadn't seen anything like this before. We worked with what we were passionate about and connected to people that could teach us. People were able to contribute as peers rather than waiting for their position. Next slide, please. Now, what's interesting about this is what's stuck. So in the pandemic, we were able to do great things. What happened as the sort of old world bit back as we sort of settled through last summer before the next crisis? And actually what happened is the things that stuck were the digital stuff, but a lot of the relational stuff didn't stick actually. So the things that were really fundamental to us developing new relationships in order to properly collaborate to meet needs, a lot of that drifted away. People didn't feel so valued. And actually, when you talk to clinical staff now, I don't know how you feel, but people say, well, we were really valued first time around, and now we're just expected to do this. And like we're tired and it's hard work. And actually, the labour of what we're doing is very, very significant. So the things that were fixed are sort of becoming unfixed. The collaborations with the communities, they're stepping up around the heroic stuff like the vaccine, but not around the day-to-day stuff anymore. We've tried, we've almost forgotten about what we've learned about collaboration. Next slide, please. So let's take an example. So often when we're looking at redesigning healthcare, we look at A&E. Everybody wants A&E to be less busy, doesn't it? And often that's about breaches. Now, on the whole, people think it's about these things. They say, demand is rising, primary care is failing, there's not enough appointments in primary care, there's no beds in the hospital, etc. But usually the solutions to A&E often reside up the top, which says there's more people coming in and primary care doesn't offer enough appointments. So we need to make primary care offer more appointments, or we need to make the community offer more appointments. Next slide. But actually, if you go and try and understand that problem, what we're finding is A&E breaches are not related to that. They're actually related to increased acuity and complexity, to more tests being done in A&E, to the fact A&E is primarily organised around trauma rather than complex needs, to the increased case management. the fact that staffing and facilities are out of pace, that the people who are staffing A&E aren't necessarily skilled at the stuff that's now presenting in A&E. So if we take that first slide, I say, if we take the proposition that more people are going to A&E because they can't get appointments elsewhere, and that's the problem, the solution is appointments elsewhere. If we take this as the set of, if we find out that this is the causal issues for A&E being busy, then actually we take a very different approach, don't we, to how we're going to solve the problem. We start looking at how do we meet complex care needs and what do we need to do at the A&E front door. And actually what we know is that for people who've got complex care needs, you need your most experienced people at the front door. If you remember back to the junior doctors strike, we were able to do amazing things about keeping people out of hospitals because we have very senior clinicians at the front door. And that's what you need for complex care. So you'd reorganise the workforce rather than reorganise GP appointment system. For instance, if this is the case, it's just an illustration about the need to really understand what's happening, because otherwise you put in solutions that don't work and they're for the wrong problem. Next slide, please. So what we ask when we're doing any work is that we what we can do is this is good diagnostics for those of you that have got a diagnostic brain on you, a clinical brain on you, which is you say, well, let's have a look. We've got these symptoms. What are the patterns, and then what might be the underlying causalities? And you do the same stuff in terms of understanding and getting into change processes. That we could sticking plaster the symptoms, but actually it won't really change the system. We can intervene at the patterns and that might help, but it really, until we get onto the causalities, we'll never do anything. In Rob's trust, before he was chief executive, we did some work about people with mental health issues who are being discharged in the community and bouncing back into mental health services. How do we help people stay in the community? And actually what we found was that if we took an asset-based approach, if we enabled those people to take an effective role in society, to have meaningful lives, they didn't bounce back. But otherwise, we'd be getting into this to and fro about, well, actually, we just need to keep them out. We need to give them somebody. We need to give them more medicines. We need to give them a person. And actually, they needed a better life and different connections. And the Creative Minds programme at South West Yorkshire Partnerships Trust is a fabulous example of getting to those causalities and doing something incredibly different to meet needs. And it's meeting needs that really matters. Next slide, please. So and I guess one of the issues that we're going to have to do here is that we could very, very quickly move through, so I'm being distracted by the chat, very, very quickly move through from we've been there and now we're going to be into this next recovery so-called phase without recognising that previously what's happened before in these, when we had swine flu or any of these major disasters, that the moral harm that people have experienced has meant that they're less able to undertake the same level of activity without it being properly acknowledged. And so if we were going to get under what do we need now within the pandemic, what's really going on now, or top tips for change, the first thing we have to do is start with our staff, celebrate what we're proud of during the pandemic, but also recognise what we're sorry for and bear witness to people's moral injury, to the harm, the very difficult decisions that junior doctors have had to face. Potentially denying ICU to 60-year-olds, potentially seeing many people dying that you wouldn't expect to in one day, the difficulty, the harm, the emotional labour of that, and how do we create spaces to heal? For those of you that know Schwartz rounds, that might be one place that you recognise as a way of doing it. So next slide, please. So when we're thinking about change, top tips, find out what's really going on around here. Go where there's passion, work out whether it's a tame or wicked problem, so what type of problem it is, because that changes the way you intervene. Do those people know each other? Because as Rob said, if you don't, you own what you create. If you are not connected to that problem, you can't solve it. So if we're talking, next slide, please. If we're talking through to, and again, and again, and again, thank you. If we're talking about universal healthcare, the problem we could have is the problem around universality, the provision of healthcare, poverty. If we think the problem is poverty, the answer is money, and the process is hierarchy, getting money to people. Is the problem of universal healthcare that people are hard to reach? If they're hard to reach, the solution is tweaking the process to find, to try and improve the communications, and you do incremental change. Or is the problem of universal healthcare that people are easy to ignore, in which case we would be providing where people really are, and that's an innovative and co-production approach. So when we're looking at the problem, back to that symptoms, patterns and generators, we've got to determine what the problem is. I think in terms of universality of healthcare, i.e. everybody having equal access, free at the point of delivery, based on need, what the vaccine has shown us, is that we are able to go find people. All those hard to reach people are getting vaccinated by vaxi taxis, by buses, in mosques, in schools, in community services. We've gone out, reached and found people who are apparently hard to reach, that we don't reach for diabetes, for musculoskeletal pain, for complex health needs. Some things we ask those people to catch 3 buses with their kids, with no money, to get to an appointment that we've decided on our agenda at a place of our choosing. And actually, if we're going to take that causality issue way out of this problem, we will be looking at what have we learned from the vaccine? What have we learned from the way we've done healthcare services in the last year? What we've learned is some communities and some people, young people, Black and ethnic minorities, but primarily poor people, are not getting access to the healthcare that we all have a right to and we all deserve. And as we're beginning to redesign services out of this, we have 2 things to do. We have to do something about enabling people with moral injury to secure some moral repair, so health service staff to recover, and we have to redesign services based on needs and move out to where people really are. So you own what you create. You have to start with what the problem really is. We can't stick in plaster anymore. We have to get to the causalities of the health system to find out how to redesign it. Thanks very much.
Thank you very much, Becky. I was going to ask around what some of the key principles would be, but I think you've probably answered that, and there'll likely to be many more questions around some of the learning from the pandemic and other examples. But what we'll do now, if it's okay, is we will move on to Carl's talk, and then Becky will come back to some of the questions at the end, hopefully. So it's again a pleasure to introduce Carl Davis. So Carl is a physiotherapist by background. He's currently the director of MSK services at Berkshire West Integrated Care Partnership, having done some brilliant work before in Surrey in terms of large-scale transformational change in the MSK services there. Carl will be talking about the application of transformational theory to create meaningful and sustainable change in complex system. Carl, over to you.
Thanks, Larry, and great to follow Becky and Rob there, and I think hopefully there's some harmony in what we're saying. Just a little bit about background on me. Up until about 10 years ago, as Larry said, I was a complex pain specialist physio, and it struck me that a large percentage of the patients that presented were not because their pain was complex, but because their complex needs hadn't been met earlier in the system. So I sort of left clinical practice about 10 years ago to explore that, went into very different roles in commissioning, operational management, and noticed that people genuinely agreed on the need for change, and they wanted to change, but were often disempowered. And so studied, sort of qualified in change theory and methodologies, Prince 2, Agile, that kind of thing. But the question kept plaguing me that if we know all of this theory, we understand what's important, we understand how important culture climate is, why are we still not changing? Why are they being held back, and why are we disempowered across the system? So I'm undertaking a PhD that examines that, and today hopefully I'm going to share some of the things I've learned along the way, and hope that's helpful. Not necessarily that it's all the right answers, but things that I potentially picked up along the way. And then I'll just quickly touch on the work that we're doing in Berkshire West, specifically around our MSK partnership. So next slide, please. Oh, next one. So one of the things that I found, and one of the things that I'm looking at, is that the way we govern systems performance can often affect our ability to get the outcomes that we want. Essentially, too much control can inhibit our ability to create meaningful change and innovate, inhibit our ability to build those relationships that we know are really important, and therefore create sustainable change. And that's because they tend to direct our efforts away from doing what's right for the long term towards these kind of short-term quick fixes, sticky plaster type solutions that appear logical but actually create more problems as we move forward. So we also find that we use KPIs, and that whilst they give us the reassurance that we're performing as a system, actually they're probably too simple an abstraction to be meaningful, and they often detract from what actually matters, the patient. So they're actually quite poor proxy measures often, and they become the focus when actually we should be focusing on what the patients tell us and what they think is important and how we can actually meet their needs. So rather than tracking hundreds of KPIs and being reassured by that, perhaps we should shift the focus away from those towards the people that we're supposedly serving by doing that, and listen to what those patients tell us, what they think needs to change, what their journeys look like, and let that inform the change that happens across the system. And that desire to control KPIs sets the scene for how well we can empower people and create meaningful change. So bearing in mind what Rob and Becky have said, it's worth considering the impact that that has. Next slide, please. The other thing to consider is complex systems are not designed. They emerge over time as a result of lots of small changes, responses to short-term changes. So it means that nobody, and also everybody, are responsible for anything that you see and the outcomes that we're getting as a system. And that makes it quite difficult, because it makes it difficult with regards to our accountability. It makes it difficult with regards to understanding where we should invest and decisions that we should make. And ultimately it needs us to start to think about it being somebody else's issue. And often managers get the blame for things that we've created as a collective. And if we've created them as a collective, we probably have a collective responsibility to help solve those problems. So there's little value in blaming people, and when we look at problems in complex systems, we'll only ever really understand part of the problem that we see. We won't understand the whole problem, because we're all at the mercy of our own bounded rationality. I mean, we'll look through our lens with our biases, and actually the problem might look completely different to somebody else in the system. So bringing those people together, recognizing the importance of doing that, really, really important. Next slide, please. So as Becky and Robert both said, again, this is about people and about inclusivity, and it's gone are the days where it should be about charismatic leadership and those kind of single heroic saviors that swoop in and solve these problems. Diversifying the input and understanding the problem from lots of different perspectives, really, really important. And that only works really if it's authentic and genuine, and we commit to genuinely listening to co-designing both the problem and the solution, so that we get that agreement and that harmony and that commitment towards solving the problems. And also removing the ego, so there's not one single dominant voice. Acknowledge that we don't have the answers individually, but we probably do collectively. So bringing those people together, hearing all of those different thoughts will help us refine, well, firstly, make sure we're focusing on the right thing and refine the sophisticated solution that we want to deliver the results. And remember that disagreement is not to be avoided. You know, it's a really important part of shaping that answer and those solutions. We need to hear those voices, and actually either they might well change when we can share what we've learned, but also you might help, it might refine your thinking as to what the problem really is. Next slide, please. Social systems can't be deconstructed in the way that we've tried. They're not machines, so we can't just reduce them down to their basic components and hope that if we focus on them, that will mean that we end up with the right outcome. Essentially, we can't see the interactions and behaviours, and often they get missed. Those spaces to build those relationships and to put time into forging those relationships, and that coherence across the system is often left and moved to one side whilst we focus on what we think the problem is. And we're also often really good at thinking about that we need more of us. We're not so great at accepting that perhaps the system needs less of us or more of something else. And so it's really important that our collective responsibility to ensure that we get the most value from any investment that we make. Next slide. It's less about the detail of where we are and where we want to be, and it's far more about the interactions and relationships that determine what the problem really is and how we can solve that together. Too often we focus on what we think the answer is, rather than what people across the system agree are the problems and how we can work to actually make it a reality. We can all kind of recognise that we're at point A. We can all say that we want to get to point B, but unless we can describe the process in terms of what the actual problem is and how you'll get there together, we're unlikely to succeed. So if you don't recognise the amount of work that's needed, you probably won't allocate the right amount of time and resource, and what's needed, ultimately, you won't create sustainable change. So just to echo what Rob said earlier, infrastructure, culture and climate become really, really important. Just briefly, just to touch on Berkshire West, next slide, sorry. This is really just to represent that we're trying to think about how we make decisions across the whole system and how do we underpin it with some key values that we're all going to work towards. So you can see we've got the clinical services, but we've also got wider system services that all play a role in supporting patients with MSK conditions. And unless we actually all start to work together and build those relationships and interact across the system, we're probably not doing justice for the patient, and we've not really got a coherent system that's working in the best interests of the patient. I think I'm running out of time, so I'll just go to the next slide. So essentially we're saying govern what matters, look at changing, we're going to look at changing the governance structures. Our approach to sort of managing contracts, working in partnership, we're thinking about changing those. We're thinking about how can we distribute leadership and decentralize the power and influence and allow those that work on the ground and deal with the detail and day-to-day to help shape both the problem and solution. And we're always going to remember that the patient should be at the center of every step, and that means sort of process, policy, procedure, all those things that we've introduced to try and get an element of control. Perhaps we just need to revisit them and think about, do they work in the best interest of patients? Backing up the talk, so thinking about, we talk a lot about things like patient-centeredness and self-management, but do we really invest in time and resource to help facilitate that and make sure that works? So we're going to do that. Again, collaboration been a key focus of this series of presentations, I think, and we're going to make sure that we move away from competition. We're going to work as community practice in partnership and in true collaboration and co-design. And importantly, we're going to try and avoid silver bullets. We're not going to think that simple solutions that we just drop in are going to have radical change. It's not going to happen. We're going to commit towards working hard towards a much bigger vision. And over the course of the next couple of years, we'll complete around 40 projects around transforming the MSK system by the end of the programme. And what we're hoping is that we'll deliver essentially not only a reduction in the pressures on secondary care, that should be a byproduct of what we deliver, but we'll be focusing on significantly improving the quality and outcomes across the whole system for the patient and letting what they say guide our decision making through that process. There you go. That's me, Larry.
Fantastic, Carl. Perfect timing there. Carl, I can just ask you one question, maybe an opportunity to reflect on sort of the shift you made to Berkshire West. What would you say has been the most important thing for leading change in the current NHS, which is obviously going through lots and lots of changes at the moment?
I think it's probably twofold. First, I'd say letting go of the ego is really important. You know, often ideas get dominated by one particular interest group, and that distorts the balance. And if we're going to work in the best interests of the patient, then we probably need just to let go of that and actually be honest and open about not understanding the problem, and actually that we collectively probably have different pieces of the puzzle, so we've got to work together. And then also just remembering why we're doing it. If it's about patients, it shouldn't matter that it's your job to do something specifically, and change might adversely affect what you perceive to be your role. I often go into most jobs focused on management or transformation, knowing that if I do my job well, I'll make myself redundant. And so hopefully we go in there then and we empower people and we actually improve the system, and it means that we need less people and less resource, but we deliver better outcomes, and that really should, for me, be at the heart of everything that we do. So
super, thank you. We'll come back to you on some questions towards the end as well. So last but certainly not least, our final speaker for this afternoon is Mike Turner. So Mike is the Chief Operating Officer at Connect Health, and he's been there for some time now and has seen the organisation go through different changes and also some elements of service redesign. Over to you, Mike.
Thanks, Larry. Next slide, please. So I thought it might be useful just to say a little bit about me to put the rest of what I'm going to talk about in context. So as Larry said, I've been at Connect for about 5 years. Prior to that, I worked in the NHS, principally managing a large transformation programme that crossed a number of organisational boundaries. That was for about 3 years. And then, among other things, in my previous life, spent about 10 years working in change and improvement projects in health, but across other parts of the public service, as well as in private sector organisations during time with Deloitte and KPMG. Next slide, please. So what I want to talk about today really is my reflections from that time, I suppose, the thick end of 20 years involved with change and transformation type initiatives. My reflections on some of those experiences, which includes both things that I reflect on that worked really well and were recognised as working well, and some that really didn't. And so what I'm going to share is some of my takeaways, the lessons I personally take forward from those experiences. And in the form really of some thoughts, some reflections, ideas, And the things to consider and challenge, all that we taking part in this webinar today will have their own experiences. I think based on what's been said today, there will be some things that I say that I think are consistent and will chime, and maybe some things that won't. So I share them in the spirit of the things I've learned. Next slide, please. So I've tried to boil those reflections down into what I think are 7 key themes, and I'm going to talk through each one of those now. Next slide, please. So I think the first one, which is key, and I think it comes out in shades of what we talked about today, is getting that balance between sort of ambition and pragmatism or realism. And I think my kind of reflection, my lesson learned is in starting when we're considering a change, some kind of transformation that we might be feeling is necessary, start by thinking big. So have that really clear vision of what we're trying to achieve, and imagine the full potential of what we could achieve. What would the system, the service, whatever it might be, what would it look like on its very best day if it was everything we wanted it to be? And don't start off by being too constrained by the likely obstacles and the barriers that we undoubtedly will encounter. The logic in my mind for that is it's easier to rein your ambition in later, when in light of practice and those experiences and the barriers coming up, than it is to expand your vision and your ambition later. So start by thinking big. But in terms of then moving to implementation, start by implementing smaller. So thinking about piloting things and learning from those pilots, reflecting that learning back into the vision and the aims and objectives of what we're trying to go for, breaking the change down into manageable elements or stages, and ideally things that we have confidence will deliver benefits along the way. So not waiting for a large initiative to complete before we see any benefit. How do we get some of that benefit as we go? And I think key to that, and this is I think also come out in some of the other presentations, is identifying, celebrating those successes along the way, so that we build that momentum and that buy-in and that sense of achievement as we're delivering the change, again, rather than wait till the end. Across all of that, though, probably a key message at this point has been really clear. What are we trying to do and why, and making sure that that's foremost in our mind as we proceed. Next slide, please. So the next one, I think this is kind of a key thing for me, is not assuming understanding. And here I mean assuming understanding of the key stakeholders to the change. So clearly we need to be really important who our stakeholders are, but really then getting to understand what are their motivations, what are their needs, and that clearly could be patients in the context of healthcare change, as well as a wider variety of stakeholders who be involved. But testing their motivations, needs, what do they really see, what do they need, but what's their understanding of the problem and what we're trying to do and why we're trying to do it, and then building on that to seek active participation in making the change, rather than just accepting passive support. But for me, that's key. That level of commitment and buy-in from those key stakeholders, and hopefully within that, then you'll identify that there are some of those stakeholders or stakeholder groups who will become key advocates for that change, and it is important to kind of focus and support them, in order that they can help build that buy-in and again maintain that momentum for the change that we're looking at. And then keep testing that throughout the change, rather than assuming because we start with commitment and buy-in that will be there throughout the course of the change. It will generally follow a curve of ups and downs, so kind of really working at that. And I suppose my overall reflection is the amount of time you think you might need to put into that communication engagement piece throughout a change is at least double it, and then probably add 10% on top of that. Next slide, please. This is another theme I think has come out today. So establish the facts. Be really clear when we're making a change where we're starting from, and what evidence are we using to inform that assessment, whether that be around our performance, costs, outcomes, whatever it is that's relevant to the change we're making. Use that also to inform our understanding of what works well and should be kept, what elements of the system that we're looking at are already performing as we want them to and are effective, and what are the real problems and issues. What is it we're really trying to focus on? What data are we going to use to inform that thinking? And then really important across that, to gain, back to the stakeholder point, gain some sense of consensus, that we all agree what the things to keep are, what the problems to be considered are, what data we're going to use to inform our thinking now and as we progress, so that we all start from the same page. Next slide, please. I think this one probably will be obvious and is much talked about,
but the idea of talking to those people as we're considering what the right course of action might be, what the change might need to involve, talking to those people who really know what's going on, and often that will be talked about as talking to people on the front line or on the shop floor, depending on what industry or sector you're in. But identifying these people who do day to day and really getting their insight. My kind of reflection, however, which again I think has come out in some of the earlier conversations, is for any complex system level change, the wicked type problems that we're talking about, the reality is that they'll have many different drivers and constraints, many factors, many elements to consider. And it's unlikely that any one group of stakeholders are going to understand all of those elements or have the best, the right, the most informed perspectives, answers, or insight across all of that. So it's really key to explore different groups of people and what they are, what their views are, and then bring all that together, and then identify what the compromises might be and what the trade-offs might be, and be really open and honest about that. Next slide, please. Manage expectations. Again, I think that's come out today and is really key. Just being really transparent from the start of a change, and then right throughout, and keep testing that those expectations are understood, keep communicating. And I think key for me there is don't ignore gaps. If it becomes clear that there are gaps in understanding or commitment, those expectations aren't being managed, then do something about it. Hoping that will all be fine, it will be all right on the night, rarely ends well. And that key thing is generally stakeholders, that they're willing to roll with the changes if they understand and have visibility of them. Next slide, please. This one, think about the benefits, I guess is a kind of very projecty kind of angle. It's hard work to be really clear what the benefits are we're looking to achieve, how we'll measure them and how we'll demonstrate them. And it's often neglected for that, but it's key. How will we actually know that we've achieved what we wanted to achieve, and whether we've been a success or not, unless we know how we're going to measure it and what we're measuring? It was interesting, Carl's point around some KPIs being sort of almost perverse incentives. Absolutely, but in the context of change, whatever we think the identifiers are of success, and knowing when we've got there, being clear about that, keep testing them throughout the process, and again, engaging with your stakeholders around those things. Next slide, please. And then the final point, inevitably, you need to be flexible. For anything that's big and complex, any kind of change of that type, the reality is that all of the assumptions we make at the start, the approaches we think are the right ones, they'll all be incorrect. Nothing will be absolutely perfect. Lots of things will change. So we need to approach change with that mindset of being willing to change direction, adjust our priorities, constantly go back to that overall vision, that goal, that ambition. Why are we doing this? And testing how we proceed against that, and not being too much of a slave to the answers we held dear or thought were the right ones at the start. And then again, keeping our key stakeholders in the loop as we're making those changes. Don't just do that behind the scenes. Make it really clear what we're doing and why, and what we can expect to get at the end of it. Next slide, please. So that quickly whisk through some of the things that stand out to me as key reflections. And the reality is those and any of the other factors that we've talked about today or will be going through people's mind, they're all interconnected. That's the reality of complex change. Lots of knock-on effects from everything we might do and everything we might think. So we have to accept that. Next slide, please. And therefore, as we approach service design, just accept that it's complex. That's the nature of it, and be prepared as we start that to balance the knowns and the unknowns. And recognise we'll be using facts, but we'll also be just applying judgment. And accepting that level of ambiguity and uncertainty throughout. It comes with the territory. You can't control it, so don't try. That's me. Thanks, Larry.
Brilliant. Thanks, Mike. So, Mike, I'll ask you a question and then we'll go straight into the Q&As. I guess the question for me that came up during that conversation is one of how do you embrace emergence? So I think you touched in that last aspect there, because sometimes with things that are complex, you might go into it with one perspective, but other things might emerge as you go through that. But also added to that question is how has Connect Health embraced change? What systems or things have you had in place to achieve that change across the organisation? Because from afar, there's been quite a lot of change in the last few years within the organisation.
Yeah, okay. So I think the emergence point, I don't have a very clever answer for how to control that or manage it, rather than just be open to that reality and keep talking about it. And back to that point of who your key stakeholders are and who those people who are experiencing or benefiting or maybe not benefiting from the change is constantly checking in with that experience, that understanding that people have got, because that's likely to identify for you the things that aren't what you thought they were, and then being open to, again, not being a slave to the methodology or the approach or the solution that you thought you were starting with, just being really open to flexing that as you go along and accepting that from the word go. It's almost part of the scope of a project, is it's not going to be what we thought it was going to be. That, you know, have that in mind right from the start. To the second part of your question, so at Connect, I think the stakeholder piece is one of the things we've focused hard on, and I don't think, you know, I wouldn't sit here and suggest we always get that right, but trying to be really clear, and this might be with internal, within our organisation, or external stakeholders. Who are the key stakeholders to the change? What's their perspective? And then keeping on top of that. Again, the risk is, and certainly I've experienced this sort of over the years of being involved, is you put a lot of time in at the start, really understanding your stakeholders and their perspective, and then kind of assume that's put in the box, great, we'll carry on and do what we're doing, and then at the end of the change almost go back and say, so is it what you thought? Is it fine? That just doesn't work. So I think one of the things we've done is put time and effort into that. And then the other really practical one is all of this takes time and effort of people's resource to manage a change, to engage with your stakeholders, to keep an eye on your risks, whatever it might be. Is just be realistic about. And it's a bit like the earlier comment of things take longer than you'd like or you thought they would. Yes, and it will take more resource than you thought you would. So try and create that headroom for change. Don't try and do it on a wing and a prayer.
Super, thank you. So this first question, I think I'll address it to Carl first because that's who the question's been asked to. But I'd also get the views of Rob as well as Becky. So Carl, you mentioned moving away from competition, but how do you achieve that in practice when organisations are potentially fighting for recognition and even survival? And I think it'd be important to kind of think about that question in the context of systems achieving what they're designed to do. You know, so we're now apparently moving towards integration, and whereas in the past the system has been set up for marketization and competition. So reflecting on the past and I suppose the future, how do we move away from that competitive stuff which often underlies those relationships as well? What's your thoughts on that? I'll come to Becky next after Carl.
I think first and foremost, you have to remember why competition was created. It was designed. It was created because we thought it would give us the best outcomes. And what we've learned over time is that perhaps it doesn't. There are some trade-offs that you have to have. And so really, it's a call to people that actually have control over and influence over how they govern across the system. For me, and so that we don't look to do things that unnecessarily create competition, and actually we enable those spaces and time and partnerships to form and flourish. That's really hard. Like you say, there's no simple answer. If you're stuck in a system that has already got a very competitive environment and you need to fight, that's a really difficult challenge. And I think it comes back to what Robert said earlier on around if you haven't got the climate, the infrastructure and the culture that is what enables that kind of joint working and partnership working, it becomes really, really difficult to get sustainable change. So I suppose there's an argument to say people want the same outcomes, people want to achieve the same things. We all want better services for patients. So perhaps engaging with those people that have the ability to influence the approach that's taken and the culture and the climate, and sort of to have conversations around why there might be different ways and what other options exist might well be beneficial.
And Becky?
Well, it's a false narrative. I mean, competition is dead. No health system in the world is using it anymore. It doesn't work. And we are interdependent. There is more demand than there is money to service that. There is certainly a significant amount of unmet need. What on earth are we competing for? The idea that it's about the survival of institutions, I think, is really flawed. So the only way we survive, as Rob, you should talk to Rob about this more than me, really get beautifully demonstrated, is recognising our interdependence and working at how do we collectively meet needs. And our job is not to protect institutions. Our job is to meet people's health needs, and protecting institutions is what's got us into the situation where we are, where we are treating black and brown people differently from white people. So this has got to stop. We've got to start with need. We've got to recognise our interdependency. We've got to look at how do we design services around needs. And that means that institutions have to adapt, and they do where you work very honourably in service to an ethical and moral collective goal.
I'm happy to come in, Larry. So I think, so obviously I think the narrative is important, and I think someone described to me once, it really stuck with me, that we should stop organising services around our own egos and start focusing on the people that we're here to support. And that requires a certain style of leadership, and that's a start. Having a compelling narrative which taps into purpose and meaning for people is incredibly important. And once you sit down and talk to folk, I think Mike just talked about this, it takes time and effort, but once you sit down and talk to folk, you realise everyone's got the same fears, everyone's got the same dreams. They might describe them slightly differently, but they tend to be very similar. So you can do that. But I do think there are also some practical things you can do. So you can take away the financial threat. So we moved to aligned incentive contracts with our acute hospitals, and that stopped any sense of, well, we're in an adversarial relationship because they're trying to take money off us and we're trying to make sure we get our money off them, which then allowed a different conversation. In other places, so in Wakefield, we've got a mental health alliance. All the money is given to the providers collectively to deliver the outcomes that are required for people with mental health issues in Wakefield. My trust hosts it. In the original sort of development of that, people said, oh, you're going to take all the money. The first thing we did was give the third sector a load of money because we got it late in the year. We couldn't spend it on anything meaningful. They could. That immediately took away some of the fear. We then talked to one of our partners, an independent sector organisation, who was doing poorly on Recovery for IAPT. And we said, now we're not in competition with each other and we're in an alliance. Do you want to know how we do it? Because we're doing better than you. So it's not a trade secret, now we're collaborating, now we're partners, now we're not a threat to each other. Let's work out on what's the best way to deliver for people, because we're all assured we've got the money. The money's the money, we've got it, we can see it, we can feel it. So I think some of those practical things about taking the fear away of competition, taking the financial incentives away around competition, will help drive a different conversation, and that can go even faster and better where you've got good relationships around shared purpose.
Brilliant, thank you. Mike, did you want to add anything to that at all?
Not really. I think that just the comment, which I'm sure is obvious around that, is that then leadership is key to that. So that's setting that tone and that environment from the top down, and then you've got a fighting chance.
Super. So this next question will go to Carl, if that's okay, and then I'll come to Rob afterwards. So the question is that there's lots of issues around cultural change in an NHS, particularly around staff expectations and expectations. How do we move forward with making sure we're able to deliver change that meets staff experience and needs?
I suppose making sure that they're engaged in that process and it's not done to, there's two parts to culture. There's the overarching framework and the infrastructure that we create, and making sure that people have safe spaces to air their concerns and share their stories. And then there's also the part which they play a role in helping shape those solutions. So I suppose it's those two things. There's only so much you can do, and a system will move as fast as it will allow itself to be shifted, and certain key leadership positions might be able to influence that. But just starting to chip away and create those spaces becomes really, really important, I think.
And to you, Rob. So I guess I'm thinking also about some of the things that Becky mentioned, and from the work that she's done around some of the moral injury, but also the process that staff are going through. When we talk about change, often it's often top down, Obviously, in the work that you've done, Rob, that's not the case. Is there any thoughts and ideas about how to bring staff along and making sure that cultural piece is embedded? Because often that is a key predictor of success.
So all organisations, you're not starting with a greenfield site. So you're in an organisation that has a culture, and you got to understand the culture and experiences of people. And you got to experience that firsthand. You got to talk to them face to face. I think somebody said once, leadership's a combat sport. It's a direct contact sport, isn't it? You need to talk to people. You need to see where they are. You need to see what it's like for them. So at the root of this, I think, is something about responsibility, which you've got to get over with staff, which is quite a scary thing to do. And I think what you're asking people to do is take responsibility for doing the job and improving the job, rather than being passive recipients of being told what to do from the top. And you've firstly got to recognise that that's quite a scary place for somebody. You're expecting me to take responsibility for changing things. That means I might get the blame. So I think for the kind of tone that you set is important. And the simple thing I always say is that I'm very happy to remain accountable, but I'm giving you authority to act. And that permission is more powerful than I imagined in my career. I've always thought that it's so powerful to give that away, to give authority, but retain accountability yourself. So I'm accountable for the safety of everybody in the organisation, the value of every penny we spend, and the well-being of every staff member. So saying that to people and saying, look, you've got the authority, and I'm giving the responsibility to change, but I'm also giving you the tools. And that means that we train 250 people a year in IHI accredited change programs. We help and support them. We stop doing things that don't work, and we trumpet and celebrate success when it happens. And over time, you recruit people who want to be in that kind of organisation. Over time, your organisation changes and becomes an organisation that feels owned by the staff. But it can be ruined in a day. That culture can be ruined and wrecked in a day by your actions. So it's something that requires constant attention, I would say. But those features of giving people authority and retaining accountability yourself, giving them the tools to do the job, and celebrating success are all important features, I think. Have we lost Larry?
I think we have. I'll leap in though. I think there are some things you can do that are very, very simple, because I think when I'm looking in the chat that people are quite worried about, we've got to be at the top to do this. And so let me just, I was at lunchtime talking to a GP that was at an LMC meeting, and she was saying that somebody at the meeting said that they were leaving and they'd been really unhappy in their job for the last 3 months, and they were leaving next week. And she said, we didn't know this. And that really struck me, because these are people that have been meeting in this at the LMCs every week for all during that time. And it meant that what they hadn't done at that meeting, they hadn't checked in about each other. How are you? How are you today? So what they've done is leapt from Zoom to Zoom to Zoom to Zoom to Zoom. I've been at Bromley by Bow here. I've got another meeting there. I've got another, you don't have to travel in between. If you don't do that, how are things today with you? How are your family? How's your home? How are you feeling? What's going on in your life? And, I think, Rob, I know you do that really well with your team, but you might forget how important it is that otherwise you're just doing the meeting, and the meeting is actually only as good as the people's attention who are in that meeting, and their attention is only as good as whatever they're bringing into that meeting themselves. And so, I think that the very first place you can start is that, how are you? And then at the end of the meeting, and how did we do? Did we do the work we thought we should have done? Have we done as well as we could have done? What would make it better? And those are very small few minutes at the end of any session we have with others, but it really helps develop the culture just with the people It's very simple, but it does make a little bit of difference. It changes the nature of how we relate, which is that we care about each other and we want to do better.
this will probably be our final question. This is going to go to you, Becky. This is around some of the learning that we've had from the COVID context. So the delivery system around PPE in the early days was seen and was an absolute disaster, partly probably due to how the problem was viewed, whereas the vaccination approach has been largely a success, again, partly because maybe the community and assets have been recognised and brought into that. Do you have any views around these approaches, how they differed, and what lessons we can learn in terms of future service design, but also how we approach complex problems?
So this is a very unpopular response, which is that a heroic NHS delivered both of those things. That being heroes means that some people turned up to work to save lives, putting themselves at risk, despite the fact that across the world people were messaging some of our clinicians saying, don't do that, don't put yourselves at that level of risk. And that's caused, I think, has caused real distress. Now, we know that there were all sorts of reasons for that, but however, with aerosol generated COVID, some people have had very, very difficult personal experiences as a result of being heroic in those conditions because they felt like they had no other choice. If we treat our NHS staff as heroic, we expect them to do things that I think are unreasonable. But we play into that. And the vaccine, we did the same thing at the beginning. GPs jumped into it. I can't imagine a less useful thing for a GP to do than be jabbing someone's arm. And actually, of course, that has changed dramatically in the last few weeks as healthcare assistants and volunteers are stepping into the space. But there was a desperate need to be valued. And general practice had felt that it hadn't been particularly valued during the course of the pandemic. And here was a moment to be heroic and to be valued. And it was in a very expensive moment. And actually, we are moving on, and general practice is saying, do you know what, that isn't a really great use of our skills. What about all our people with complex needs? So we've got quite a complicated relationship with the public as NHS organisations and staff. We have to move into the space where people looking after people with learning disabilities, with mental health needs, people wiping bottoms and helping people helping people eat and helping people who are suffering and holding people's hands as they die. That is as valued as this heroic saving lives version of the NHS. And so, I mean, that's something I think people like Rob can really do, which is to set the tenure and to start a public debate about actually what really matters. And this is going to be the same with long COVID. You know, with the, do we really value people's lives and people's suffering whilst they're coming through COVID, as we did at the moment when they were in crisis? It's going to be a real challenge to us, which is how do we ensure that the nuts and bolts, the complex, chronic, long-term conditions that we deal with every day are seen as worthy of our effort, and the people that look after those people as worthy as those that do the heroic stuff. So I think the heroic model got us into both those situations.
Fabulous, thank you very much, Becky. Time has flown by. We've now pretty much come to the end of that conversation. I'm just going to go around and ask all our speakers for a 20-30 second summary, sort of one key point of something that they think we need to focus on to make service design redesign work well going forward. If I start with Carl, could you just give us your one-liner on one thing that we need to focus on?
Yeah, I think it just comes back to what the key theme has been around recognising the complexity and making sure that we understand the problems are probably more difficult than they first appear, and therefore working in partnership to understand that and to deliver those solutions.
And I'll come to Rob next, followed by Becky and then Mike.
When you're sick of saying something, that's when people have only just started to hear it. So my thing is communication. Never stop communicating.
Becky?
The answer is always in the team that you're currently working in. You can look at all the expertise in the world, but actually you've got it there. And so let people bring forward all the knowledge and skills and expertise that they have.
And finally, Mike.
Yeah, I think I would just make that point of assume that we don't understand the answers or the solutions, and that our stakeholders don't understand what we're trying to do, and keep asking that question till it's all over and been done.
Super, thank you. Well, thank you all for joining us. Please don't forget to fill in the feedback survey. It will literally take just 2 minutes of your time, and it will help us improve sort of future webinars that will be coming up. The next webinar is on the 14th of April, as you can see on there, and there's another one in May and potentially one in July also. So without any further ado, thank you very much, and that brings us to the end of this webinar.
Thanks, everyone.
Thanks all.